So we can get started. Yes. Technical challenges. So welcome to this month's Health Policy Grand Round here at UCSF. I'm Joanne Spetz. I'm the Institute Director, and I'm really excited about this month's talk. So LaTanya Trotter is an Associate Professor of Bioethics and Humanities at the University of Washington School of Medicine. She's a sociologist and takes an institutional view of ethics by considering how social and workplace institutions shape notions of responsibility and what constitutes good or ethical decisions by both healthcare professionals and lay providers of care. In considering how decisions around care get made, her work connects changes in the organization of medical work to the reproduction of racial, economic, and gender inequality. She takes up these and other questions in her book, award-winning book, I will note, called More Than Medicine, Nurse Practitioners and the Problems They Solve for Patients, Healthcare Organizations, and Fate. That received the British Sociological Association's Foundation for the Sociology of Health and Wellness Book Prize. Her publications have also received awards from the American Public Health Association and Society for the Study of Social Problems and the American Sociological Association. She's on several editorial boards, serves as a board member for the Johns Hopkins University Press's Health Communication Series, and is on the steering committee of the CareWork Network, an international organization of researchers, policymakers, and advocates striving to change the conversation around how we see, fund, and do care work. I first got to meet Dr. Trotter through her connection with our award network on advancing workforce analysis and research for dementia, and I'm really grateful for her engagement in that. She was on the pilot review committee that we just did, and really just thrilled to have you here. Thank you so much for coming down here and spending like a day and a half with us. So it's all yours.
Okay, well, thank you. I guess I need to stay, and otherwise you won't be able to see me over the screen. But thank you so much for that generous introduction. I'm really excited to receive the invitation to come to UCSF. I have to admit that I wasn't very familiar with the work of the Institute, but I am very familiar with the department, which I've learned on the 12th floor, the Social and Behavioral Sciences Department, which is the home department of many of your affiliated faculty. And, one of the things that was always so fascinating to me about that department is that I believe it is truly an N of one in terms of a department of not only being an interdisciplinary social science department, but being housed within a school of nursing. And so for someone who has made their career studying nursing, I found it a really interesting case and a truly strange and wonderfully aberrant case. So as somebody who spends most of her time doing active work, I have more than a small affection for aberrant cases. In the doing of quantitative work, the focus is usually on the meat, right? We sort of create quantitative descriptions of what we expect to happen most of the time for most people in a particular population. But when we're working with small numbers or with a small number of cases or even single cases, it's the detail that's in the details that is actually the most revealing. It is a very out of the ordinariness that serves to highlight the assumptions that usually go unchallenged and that magnifies the social processes that can be difficult to see in generic or ordinary cases. So the pandemic, in many ways, was its own strange case. For me, being really interested in the sort of experience of healthcare workers during the pandemic, I have read many descriptive accounts that really have tried to give us a sense of the general sense of the case. And I think when we didn't know what was happening, right, there was something really quite useful about those kinds of sort of general descriptions of what was happening during the pandemic. But I also think that it can become important for really thinking analytically about what we can learn from the pandemic, is really thinking about it as an aberrant case, which is to say, what is it about the experience of people during the pandemic what can paying attention to their experiences help us to understand about the ways in which work has changed outside of that particular period of time. So for the healthcare workers that experienced it, I think the pandemic itself was a revelation. And what was revealed was not fleeting, but was in quite definitively persistent. So in the rest of this talk, I'm going to share with you, not just my own analytic reflections of the case, but also how nurses themselves used the aberrant case of the pandemic to come to their own different understandings of what it means to be a nurse and what it means to provide care under a changing set of conditions. How did this particular experience impact their understanding of how one goes about navigating or forging a career in nursing, and how did this experience change their existential understanding of what it means to be a nurse? So, of course, I am not the first person to consider how the pandemic might have created an enduring set of effects on the nursing workforce. And most of these considerations, both lay and academic, tend to coalesce around the phenomenon of burnout. So burnout quickly is a state, defined as a state of emotional, physical, and mental exhaustion caused by prolonged stress. So given the intensity of the pandemic experience for healthcare workers, it's not surprising that during this period, levels of burnout reached epidemic proportions. So there was one survey that was conducted in 2020 using a validated scale for burnout, which reflected that 50% of all healthcare workers met the criteria for burnout. The nursing workforce was hit particularly hard, with registered nurses reporting burnout levels of 56%, the highest for any occupational group. But even more concerning than these numbers, sort of snapshot in 2020, is the persistence of burnout. So although the COVID-19 virus is still with us, we're no longer living through pandemic conditions. But there's little evidence that burnout levels are going down. Right? Recent barometers, whether they be by survey, poll, interview, shoe-leather journalism, suggest that the majority of healthcare workers are continuing to report feeling burned out by the everyday features of the job. Which for me raises the question, is burnout still the best concept to contain the experience of these workers? And is it the only or the best way to think about the enduring impact of the pandemic? So one way to consider this question is to sort of take a little short detour into the concept's provenance. Psychologist Herbert Freudenberger was the first person to coin the term burnout in 1974. And like the story of many a new diagnosis, he was acting as a kind of moral entrepreneur, right? Calling attention to what he considered to be a great evil while making the case that the tools of a particular set of medical experts, in this case psychologists, were necessary to address the problem. So in theory, burnout could be applied to any worker. But Freudenberger wasn't interested in any worker. He was interested in healthcare workers and the specialness of their mission. Because for him, burnout in physicians and nurses was a problem because one expects them to be motivated by things like empathy and compassion, right? And these are the kinds of feelings that are blunted by those who are overwhelmed by stress. So for him, the people wasn't really stress, right? The great evil was the increasing number of healthcare workers who lacked the empathy and caring ethic to carry out their professional missions as he saw it. So the problem was less the stress than the people impacted by it. So despite Freudenberger's best efforts, however, burnout never really caught on as a diagnosis. Psychologists developed and validated scales to measure it as early as 1981, but there remains a certain amount of ambiguity, right, around what exactly it is being measured. Burnout remains excluded from the DSM, and there is no movement whatsoever to consider its addition as a unique diagnosis. Burnout still has had incredible staying power in the biomedical literature. As a concept, it rings metaphorically and existentially true for healthcare providers and for those concerned with their experience in the labor force. So far be it for me to concentrate on the tools that one implements to make sense of one's particular experience, but it is simply the case that the tools that one uses has a particular set of consequences. So although not a diagnosis, its medical provenance still poises us to locate the problem of burnout within the bodies and minds of individuals. So certainly in the last few years, there's been a growing chorus of voices, of which I am only one, who have raised serious questions about the appropriateness of continuing to focus on the person experiencing burnout rather than on the conditions that produce it. And I hope at some point those voices will begin to crowd out all of the many voices that are still advocating interventions about stress reduction and individual resilience. I also think that there's another consequence of our attachment to this concept, one that raises questions about whether burnout is really best suited to capture the set of experiences of contemporary healthcare workers at all. So sociologists see right now famously observed that individual level phenomena may not be the same as those that appear in the architecture of social structure. His particular example was unemployment. And he noted famously that when one person is unemployed, such misfortune is what he called a personal trouble. But when millions are unemployed, it becomes a public issue of social structure. So for Mills, the transformation from private trouble to public issue is not just about the demographic weight or the numerical weight of the problem. Rather, he's putting forward the idea that individual problems are not even the same kind of problem as those that are located within society's social structure. So when burnout becomes something that a majority of workers experience, when it seems to be woven into the very fabric of how the work gets done, I think it's a useful time to ask, are the experiences reported by healthcare workers best conceived of as burnout? Are there other more profitable ways of conceptualizing this set of experiences? And I think the pandemic is a very useful case in which to think through this question, because as I noted before, right, I think it was numerically a turning point for burnout, right? At the time, the levels that had once been sort of steadily increasing over time seems to have reached the tipping point, perhaps even a point of no return. So I want to sort of keep with this idea of thinking about the pandemic then as a kind of turning point, because I think that it served as that particular kind of fulcrum in other ways for the nursing profession as well. For me, it was a turning point for moving out of the profession altogether. We know that many nurses who were close to retirement chose to leave the nursing labor force during the pandemic years of 2020 and 2021, right? That was really like a pretty significant, right, demographic shift, right? But in terms of a trend, right, the evidence is that it really is a momentary. We're still waiting for sort of new data to sort of more recent data to sort of see if what we're seeing now sort of bears itself out. But it looks like that those nurses that didn't have the financial means to retire are remaining in the healthcare workforce as nurses. So in terms of the big picture, there doesn't seem to be a sort of mass exodus of nurses from healthcare. But if you talk to anybody at the organizational level, administrators or even workers, they are observing what seems to be a growing level of instability, right, in that workforce, right? So it's not entirely clear yet, as I said before, what explains that contradiction, but it seems as if the nurses who are choosing to stay are choosing to stay differently than they once were. And when you talk to nurses, one can begin to sort of crack, right, an understanding that one of the things that may have changed is less their commitment to remaining in the profession, but them coming up with refashioning a changed understanding of a normative way to forge a nursing career. And then differently crafting a nursing career, there may then also be potential impacts on nursing practice or how one thinks about what it means to be a nurse. So, what I'm going to sort of share with you today are some my analytical reflections from interviews with about 90 registered nurses about their understanding of these sort of changed relationships. And in the rest of my talk, I'm going to sort of focus on three aspects of that reflection. So first, one of the things that I found was a sense in which for these nurses, the pandemic really ruptured the relationship between nurses and their patients that has not yet been repaired. Right? So in the medical sociology literature, there's much to do about the doctor-patient relationship and the way that it can help or hinder the outcomes for patients. But I think the nurse-patient relationship is an understudied phenomenon, right? So I think when you sort of look in the nursing literature about the ways in which nurses think about that relationship, it's not just something that shapes patient outcomes for nurses, it is something that is at the very core of nursing work itself. Second, I'm going to spend a little bit of time talking about the changing nature of nurses' relationship with their employers specifically. So nursing has always had a complicated relationship with healthcare organizations. So to give a little bit of comparison, physicians, the sort of prototypical profession, are traditionally consultants, right? They do their work, right? Sort of autonomously and on their own terms in the ideal type, right? Nurses have always been employees, right? And therefore, there are ways in which nurses and the nursing profession has always, in ways that are distinct, I think physician workforce, have always been beholden to the kinds of things that employers, right, think should be salient about nursing work. But it is also true that the organization has also played a real pivotal role in nursing's ability to become a profession. It's the organization's insatiable need for a skilled technical workforce that has actually opened many, many doors, right, for the nursing profession that makes it in some ways unparalleled as an occupation in the healthcare workforce, right? In many ways, the relationship then between nursing and their employers is an interesting material. It's an interesting material matter, but I also think that it has, the evidence suggests that it matters not just for those kinds of relationships, but it matters for how nurses go about thinking about what it means to provide nursing services within the context of these organizations. I'm going to talk a little bit more about that in just a few moments. But finally, I'm going to also talk about and think about the ways in which these sort of changed understandings of patients, of the relationship between patients and employers may then have enduring impacts on how it is that nurses go about thinking about what it means to forge a successful career. So, as I said, I'm going to talk about this sort of idea, right, about nursing and relationships for just a little bit more. So one of the things that I think is really important to spend a little bit of time talking about is really thinking about the sort of theoretical and empirical underpinnings of this sort of traditional understanding of the importance of relationships for nursing work. So nursing is a demographically female and socially gendered profession, right? And that is one of the features that makes it an iconic care work profession within care. So briefly, care work is related to medical work, but it's distinct from it medically, historically, materially, and practically. And it can get a little bit fuzzy in terms of thinking about exactly what it is that care work is. But one way of thinking about how to think about care work and what distinguishes it from other kind of work is really to sort of focus on who does it. Okay? So care work overlaps with labor that's historically performed by women in the domestic sphere. And even today, care work really is distinguished by being a form of gendered labor for that reason. So the who that performs the work bears a necessary relationship to how that work unfolds. So when people think about relationship-based work, when they think about care work, one way of describing it is that it's based less on discrete set of services or skills, but on a kind of gendered responsiveness to the needs of the person being cared for. So an example that I like to use, right, is thinking about the ways in which being a kindergarten teacher is a form of care, right? It is true that you are imparting some kind of knowledge to kindergartners. You are also simply being responsive to whatever the needs as they arise in the context of like being a part of that particular sort of social situation. So you would never say to the kindergarten teacher, I'm really just here to teach reading. I'm not here to help you go to the bathroom, right? Right? There's all these kinds of features, right, that are embedded within how we think about how that work unfolds. So in this way, the relationship comes to be seen as the bedrock of what it means to provide nursing care, not in terms of effect, but as an embodied source of expertise. Because one can only provide this kind of care by knowing and anticipating and listening to needs, right? And being attentive to the possibility of knowing the patient's relationship. So this relationship is not only about the time that frames the encounter itself, but for nursing, it's embedded within a general sense of trust that patients have historically had for nurses. Nurses never tire of reminding us that based on yearly opinion polls, Republic considers them to be the most trusted profession, right? And I think that the strains on that trust were significant during the pandemic, right? And they continue to have enduring effects on the ability of nurses to nurse in the ways in which they once did. I also want to talk a little bit about, again, this sort of relationship with between employing organizations and nursing work. So the scholar Davina Allen talks about the way that nurses provide what she calls organizational labor in the hospital setting. She writes, "It is nurses who reconcile the requirements of healthcare organizations with those of patients. It is nurses who broker, interpret, translate, and communicate clinical, social, and organizational information in ways that are consequential for patient diagnoses and outcomes. In fulfilling these roles, it is nurses who weave together the many facets of the service and create order in a fast-flowing and turbulent work environment." Right? So there are ways in which this concept is really sort of holding our focus and making us pay attention to the ways in which nurses forge micro relationships, right, in the context of the hospital service as a way of performing this organizational labor. In my own work on nurse practitioners, I found that nurse practitioners engaged in what I call organizational care work. Right? So in context of Davina Allen's concept, it's not just that it's not just that nurses reconcile patient and organizational concern, but are actually called to be responsive to or care about the needs of their employers, right, in the work of caring for patients. So in both of these concepts, organizationally embedded relationships matter for the doing of nursing work. For Emily, it's relationships forged within the organization. And for me, it's the relationships forged to the organization itself that actually matters. So when the nurses that I spoke with talked about changed understandings of their relationships with employers, this pretends, I would argue, changes not just in how they feel about their employers, but how they then might go about carrying out their work. So in terms of thinking about how to conceptualize the data that I use sort of make this story. So in 2021, myself and a team of undergraduate students conducted interviews with 75 registered nurses. And most recently, with some collaborators at the Center for Health Workforce Studies at the University of Washington, we just finished interviews with 16 travel nurses in 2023. And use these two sets of interviews, right, in a kind of iterative way, because one provides us with a view of what it was that nurses were experiencing, kind of in the thick, right, or very soon after the sort of thick of the pandemic. But the 16 travel nurses give us a sense of then what the response has been, right, to those initial sort of sets of experiences. For folks who might be interested in method, you can ask me some questions about this at the end of the talk. But I was particularly an ethnographer who got kicked out of a field site because the pandemic started. And so, like many people, I sort of pivoted, right, and tried to figure out how to make some use of this time that I had to sort of move something forward. So I want to be transparent about how these interviews were conducted. I really think of them as being ethnographic interviews with an oral history approach. Often in interview-based studies, you have a phenomenon of interest that you're actually interested in and that you're asking folks about. This study was conducted as hell. I really just wanted to understand, right, the experience of nurses during the pandemic. So I really think of them really as being more of like an oral history of their experience during the pandemic, as opposed to being about any sort of particular phenomenon. So I think it's important to sort of be upfront about that. And I also think, to just sort of give a sort of basic limitation. Certainly I didn't have any particular eligibility criteria that would filter out RNs who had left the nursing workforce, but the folks who were interested in talking to us were those who were in the nursing workforce. So they're the experience of folks who might have left the nursing workforce or not sort of captured in this setting. So I spend most of my time talking about the change relationship that nurses have with employers. But I want to spend a few minutes giving you a sense of the kind of responses that nurses gave that are helping me to sort of think about the ways in which there is a kind of persistent severed trust between nurse and patient. Because the nurses that I spoke with certainly shared their fair share of pandemic horror stories from the front lines. They told me the stories that you've all already read about or heard about their experiences with no PPE, about sort of the trauma of sort of facing sort of death after death after death after death, of the kind of unaccounted for and unprocessed grief. And even in 2021, right, these stories for the nurses that I spoke to had already begun to lose their emotional tenor in terms of how they told these stories. They had already begun the process of normalizing their most traumatic experiences. But the thing that continued to stand out to them, right, were not these stories of horror and trauma from the front lines, but it was really focused around the seemingly increasing gulf that seemed to be arising between them and their patients. From the very beginning of the pandemic, they began talking about the sort of sudden rise of the physical distance that became a necessary part of nursing during the pandemic. One nurse, and in some cases it happened in ways that maybe seem small, but that were actually very materially salient for the nurses that I spoke with. One nurse who worked directly with COVID-19 patients described, the loudness of the HEPA filters, right, as sort of signifying for her, right, the kind of separation that was introduced into what had previously been a sort of easy relationship with patients. She noted the HEPA filters were like so loud, they were definitely loud. COVID units, and I mean, that's just what it was like. So it was always like, me screaming at my patients through my N95 and then my shield, and then trying to get them to hear me. So sort of this forced separation was stories of this forced separation, newly forced separation, was a central aspect of infection control procedures. And there were other ways in which this sort of appeared, in which nurses would tell stories about the ways in which they were barred from having direct contact with patients unless it was deemed to be medically necessary. So for nurses who really enjoyed coming to work because of the kind of direct contact that they were able to have with patients, this was experienced as a significant loss, a stripping away of one of the core features of what they found appealing about bedside nursing. But this physical separation, however, seemed to portend a more ominous appearance of this gulf of distrust that nurses began to feel emanating from their actual patients, as well as their sort of prospective patients in the form of the public. And this growing distrust appeared in the narratives that nurses shared with me in ways both small and large. Right? So one of the nurses described having to newly secure their masks. Right? So she notes, we were having to watch our masks because people were taking our entire bins of masks from our floor. So we used to have like a contact card out in the hall, and we had to hide or lock away all the masks. Visitors were taking them, yes, off of our contact cards. So we were hiding our masks, right? So I mean, it's just sort of a smaller story, but this is the kind of story that was salient, right, about the sort of changed environment on the floor, and the ways in which this small act of distrust were appearing, right, in the everyday working with patients. And these small acts were underscored by larger ones. Nurses shared stories of patients arguing with them about mask policies, shouting at them about visitation policies, and starting heated arguments about whether COVID-19 was a real disease. Another nurse noted, I think that has been one of the worst things, having to listen to people say that COVID's not real, that it's a hoax, and like we're sheep and everything like that, when they don't know what it's like to be on the front lines. So they not only face this rising distress from patients, but also by relatives and close friends. One nurse reported, I was a part of so many WhatsApp group chats that I'm not part of anymore, with people posting conspiracy theories and how this is not real. It makes you so angry. So the most trusted profession, right, is reporting experiencing a growing distrust from the public. And one of the things that did not count all of these interviews, right, in 2021 but it has become a consistent theme in both the interviews from travel nurses interviewed in 2023, as well as stories that you probably have read about and shared by in lay publications, which is the rise of misinformation that has continued to erode the public's trust in medical experts in general, including the most trusted profession. And so when patients want a person to unload their conspiracy theories onto, the person who is best sort of situated for that unloading is the person who is both seen as an expert, like a nurse, but who is also available to listen to them, a nurse, right? So when we think about the persistent impact of the pandemic era on nursing care, the attenuation or severance of trust between nurses and patients is something that I think will potentially become an entrenched part of that encounter. So, I have seen medical sociologists talk about reviving the quite moribund literature on the doctor-patient relationship, but I think there's a great deal more work in theorizing to be done in really understanding the nurse-patient relationship, with a particular focus on thinking about how post-pandemic changes have fundamentally altered that relationship. So, I want to spend, a reasonable amount of time focusing in on the changed relationship that nurses have with their employers. Because I think it's probably the most salient and important set of themes coming out of the interviews that I collected. So as I mentioned before, nurses' relationship with their employers is a complicated one, right? And one of the features that makes that relationship so complicated is nursing's perennial sense that they are devalued by their employer. Right? So nurses have always worked and lived in the long shadow of the physician, right, with this sort of sense of elite status. And at the professional level, they've often felt that they struggle to be seen as having a valued perspective distinct from those of their physician colleagues. It's not uncommon for the lay public and for some physicians to believe that nursing practice consists of little more than following orders. Right? So this de-skilled view of nursing practice is not just a part of popular discourse. Right? For many nurses, they see its material impact in the wages that they receive. So while government salaries represent a solid middle class income for a profession that only requires a bachelor's degree, nurses have long complained of their wages, while initially high, remain stagnant throughout their careers. Signing bonuses and high salaries are used to lure nurses to a particular hospital or unit, but hospitals rarely offer registered nurses few rewards for either their loyalty or the sort of accrued expertise that comes with time. So this complaint preceded the pandemic, but the pandemic brought out in sharp relief the systematic provenance of these complaints. The pandemic for these nurses became the aberrant case through which they were able to begin to question their longstanding relationship with their employers. So when it came to stagnant wages, many nurses had began developing a new analysis of their systematic devaluation from this experience. So again, stagnant wages was something about which every nurse struggled, but it was a situation that they largely accepted. Many had developed sort of a localized explanation of these issues, but it was because they worked in a public hospital, it was because they worked with a high level Medicaid patient, it's because it was a rural hospital, right, or a hospital that was struggling financially. However, as they watched hospitals find money to pay traveling nurses, which seemed like exorbitant salaries, they began to develop a national a national perspective or a national analysis of nursing's low wages. As one nurse noted, travel nurses easily make double what I made for doing the same job. So yeah, doing your job with the same pay I was making before was real cool, real cool. And while some technical news pieces have suggested that staff nurses are resentful of travel nurses' higher wages, the nurses that I spoke to seemed to largely support travel nurses. One nurse who worked in New York State during the height of the pandemic noted, "Thank God for the travelers. I don't know how long we would have lasted without them." So, although we both had developed a kind of understanding, right, of travel nurses, they were less understanding of a system that seemed to rely on them. One nurse noted, one of the things that you see hospitals doing is, kind of quick fixes for the staffing shortages, which actually end up driving up the cost of healthcare and the staffing all across the board. Another nurse more pointedly asks, if they can find the money to pay traveling nurses, why can't they pay us more? So in regards to sort of feeling less valued, many nurses express the experience, right? Or they narrated that experience of being less valued in talking about the kinds of narrating their experience of taking unique risks during the pandemic as nurses. More than a few nurses noted that during the early months of the pandemic, many hospitals experienced a shortage of personal protective equipment, such as N95s and gowns. So nurses were sympathetic to the plight of their individual employees, right? As the scarcity of PPE was a national problem, they assumed that their administrators were doing the best they could under a difficult set of circumstances. But they were less sympathetic to what many say were the decision to protect other workers rather than nurses, even though they were the providers being asked to bear the brunt of the soldier. So although almost all the nurses were kind of dealing with mask shortages and being asked to reuse and sanitize N95 masks over several days, but there were two nurses who described provider level differences in who received masks. One nurse who worked in a general medical surgery unit of a large hospital noted, "We were told to reuse our masks. Many of us found ways of purchasing our own, but the physicians on the ward, they seemed to have no problem securing masks." So I want to be careful. I include these experiences not because I think that they are emblematic of nursing experience, but because of the sense that these nurses made of this particular experience, whether it was accurate or not, right? Because the sense that they made was that they were devalued and therefore treated as expendable, right, in comparison to other kinds of providers on the floor. So another example of this sort of idea of being asked to take unique risks was in regards to who was asked to bear the highest risk of infection in the hospital setting. So infection control procedures, right, not only barred families and friends from the rooms of COVID patients, but also barred most members of the care team. This included CNAs, chaplains, but it also largely included attending physicians, PAs, and NPs. So the nurses who directly work with COVID-19 patients noted that it was common protocol for the attending, for example, to rely on the nurse's physical assessment and notes in order to make treatment decisions. In many cases, the nurse was the only one to enter the treatment room. One nurse who was not an ICU nurse, but who had been asked to work in the unit due to worker shortages, described a situation in which, quote, "I literally had the ICU director one morning tell me had to stop doing our work and start mopping floors." I mean, the nurses. So for the first 6 months of the pandemic, nurses were basically doing everything. We transported our own patients, we cleaned our own rooms, we trapped at our own rooms, we changed linens, we removed trash, we did everything. And the same nurse recounted how this impacted clinical care. I remember reading in P's and attending notes about how they cared for the patient and examined the patient. And I'm like, your entire examination is based on what I told you because you never went in that room. I remember at one point a patient was pumping, crashing on a fast decline on me, and I wasn't even an ICU nurse, and I'm literally a fish in a fishbowl. Everybody's outside making decisions and just yelling at me through a walkie-talkie, telling me what to do, or talk to me about the patient's status through a walkie-talkie. But I'm the only one at the bedside. And so I think, this is a kind of embodied experience in which nurses felt that they were alone at the bedside, right? In healthcare structure in which everyone has converted to the idea of the team, during the pandemic, they found themselves alone at the bedside. And I think that this really helped to facilitate this idea, right, or this feeling that they had been abandoned by their employer, right? And there were other ways in which nurses talked about their feelings of abandonment by their employer during this time. One nurse wrote or narrated, at the time of the pandemic hit, I'd only been a nurse for, I was coming up on 1 year, but like not a very long time. And I'd only floated a handful of times. I had just been eligible to float as a new nurse. They don't let you float for a little while until you can get comfortable in the unit. And all of a sudden, my unit closed, and I'm floating every single shift. So this is sort of emblematic again of nurses feeling right abandoned by their employer in being to practice in ways that they felt were unsafe. Right? Sort of the idea of not being able to get to know the patient, not being able to get to know the worker, not even working in their specialty. Every day someplace different, every day doing something different. There were ways in which they felt abandoned by their employer and really sort of hung out to dry in ways that they felt really jeopardized their licenses. So we got maybe a few more minutes. I want to make sure that we have time for questions, right? I want to spend a couple of minutes of time, like sharing some reflections about how these kind of attenuated or severed or ameliorated relationships with patients and employers is impacting the ways in which nurses are reconceptualizing how to forge a nursing career. And again, for this, I'm drawing in the kind of response of nurses and thinking through this particular set of issues. So many of the nurses, not just the travel nurses, talked about trying to figure out ways not of leaving, but of staying in the profession, right? So many of the nurses I interviewed reported changing jobs during the pandemic or were actively planning to attend private school in order to change jobs in the future. They reported, as a previously would suggest, that the stress of the pandemic and post-pandemic conditions were leading them to think about how they could make a change. One nurse described her intention to finish a psych NP program, and she said, I don't see hospitals prioritizing nursing anytime soon, because at the end of the day, hospitals are businesses, so they cut back as much as they can. I don't want to feel burned out and end up in a situation where I hate my profession. I think that this was sort of particularly true, right, in the subsample of travel nurses that I interviewed. Many of them reported that what kept them taking contract after contract after contract was not really the amount of money, right? It was really the ability to just show up and do the job and not having to deal with the politics on the floor or worrying about the kinds of organizational stressors that come with being short-staffed. One of the travel nurses said, part of me wanting to travel was me trying to figure out a way that I could stay at the bedside. It's a kind of no commitment kind of thing. I don't have a sense that I'm not getting stuck. So I think that when we look at the literature on turnover, there really is a sort of focus on what is driving nurses to leave positions. And I think it can be useful to really think about the ways in which they're leaving, right, as a response to changing conditions, and really thinking about the ways in which they're leaving in order to stay, right? But I think that kind of shifting then how then they are thinking about the role of longevity or not, and how one goes about sort of building a nursing career, right? So one of the things that I noted or they paid attention to were what I call strategies of disengagement from the work itself, right? So particularly for travel nurses, one travel nurse said, one of the things that I like about travel nursing is you don't get caught up in the unit drama. And that was exactly what I wanted. I wanted to show up and I just wanted to take care of patients, and then I just wanted to go home. Another travel nurse noted, I realized that I'm a skilled nurse. I just want to come to work and do my job. And I think the thing that I really sort of want to focus our attention on in thinking about these strategies of disengagement is that before I talked about the idea of relationship, figuring very heavily in how it is that nurses go about thinking about how they do their work. And what I'm hearing, what you can sort of get a little bit of a taste of, are the ways in which nurses are saying, that way of doing nursing, that way of embeddedness, that way, right, of getting caught up in relationships, that way of getting to know my coworkers so that I can provide this kind of institutionally embedded care. I don't want anything to do with that. I just want to go to work, perform my nursing skills, and go home. And I think that for some travelers, they really didn't know that sort of other aspect of what it means to disengage, that it was, what they needed to do for their mental health and their ability to stay in the profession. But they also understood that there was something that had changed. One nurse said, I always thought that, that you'd become part of that family as a travel nurse. But my name on the board just says traveler. It doesn't have my name at all. It just says traveler. I'm just a body filling a slot. Right? So I'm going to wrap things up. So in terms of thinking about my sort of provisional conclusions and thinking about this set of results, is I think that it can be useful to sort of reorient this idea of turnover as really thinking about it not as a way of leaving, but as a way of staying in the profession. I think that framing might become useful as folks are thinking about retention strategies and thinking about there is a kind of hopeful optimism at the heart of this turnover that then maybe can be sort of marshaled in some kind of useful way. I'm also really thinking about the ways in which nurses, again, that sort of idea that they're looking for ways to stay, is that part of what it means to look for ways to stay is that they're looking for jobs with lower levels of engagement with direct patient interaction, but also lower levels of engagement with the needs and concerns of their employer. So when I think about this idea of organizational labor or this idea of organizational care that really sort of characterizes what it means to be a nurse, I think we'll be looking at new cohorts of nurses who are willing to say, that's not how I conceive of what nursing work is, because that's not what I'm actually going to be able to do in the maintenance of an entire career. And the third thing, don't look at what it says, right? It's thinking about sort of new moves towards flexibility. Right? And so one of the things that I learned in listening to the stories of travel nurses is the sector has really dried up. But nurses are still interested in this kind of flexible kind of work, and employers are responding. And so there are ways in which to sort of move towards flexibility as opposed to institutional embeddedness is perhaps going to become a trend that then is going to reshape, again, notions of what it means to provide nursing work and changes and shifts in what it means to display nursing expertise. So I think, to close with a couple of final thoughts. I think it can be I think it's important that we sort of rethink the utility of burnout. I think that this idea of burnout is problematic in part because it comes out of a kind of diagnostic psychological toolkit, but I also think that it comes from this perspective that asks us to think of healthcare workers as some different species of worker than any other kind of worker. That we have to come up with new terms like burnout or mental distress or compassion fatigue, as opposed to thinking about it coming out of problematic living relations and problematic working conditions. And there may be terms that are already existing to sort of talk about name and framing these kinds of experiences, but don't carry that kind of conceptual baggage that burnout does. And I think, moving forward, I'd like to see us sort of refocus our attention on the importance of changing relations, particularly with employers. Because when I think about what has been claimed as special about nursing practice, really depends on these relationships. So if we start thinking about what many people like to think of as being perhaps the potential gigification of nursing work, we're really going to see a kind of implosion, right, of that kind of expertise that I think is important to sort of consider. And finally, I think that nurses are already changing their understanding of what it means to forge a nursing career. And I think that it's important to sort of think about the relationship between those changes and the ways in which they might bear some relationship to future changes in practice orientation. So I hope you all have questions because I'm interested in hearing them. Thank you. Oh, acknowledgements. I want to acknowledge for the travel nurse interviews the support that I received from the UW Center for Health Workforce Studies. They were really valuable for funding, but also supporting and theorizing about those interviews. So thank you.
Of course, I have questions. I'm another one of those non-nurses who studies nurses a lot. Some of what you're describing has echoes to me of what we heard and saw in the kind of, I'd say, late 80s through early to mid 90s when the managed care revolution was underway. And hospitals, during that time, there was some conversion of hospitals to for-profit status, but the much bigger trend in much of the country was hospitals joining multi-hospital systems. So the hospital industry was becoming somewhat more corporatized. And during that time, you heard these rising concerns, plans to quit. Wages did stagnate during that time period. And in some places, like California, you saw the rise of the California Nurses Association. That really was when they rose. And some of the rhetoric associated with the union, and the CNA broke away from the American Nurses Association, which was a really hot issue. And some of the underlying discussion was around the American Nurses Association saying, leaving your patients in a strike is not professional, right? Like that severing, I never thought of it this way until your presentation, of that severing that relationship, or what is that relationship with your patient? Whereas the leadership in the California Nurses Association basically said, look, hospitals this is a feminist issue. Hospitals are profit driven. They are not treating us well. They're not allowing us to do our work. And they're not going to listen to us unless we actually walk out there and go on strike. Which reflects a lot of these themes of, did hospitals in some places over that time period begin that severance of the relationship with the patients? Develop a severance of the relationship with the organization, because now you're not employed by hospital, you're employed by Sutter Health, whatever that giant enterprise is. And so I hear these echoes in the data we just have in for California's survey. Something like more than 50% of nurses say they plan to leave their current employer in the next 2 years. But the percent that say they plan to quit nursing entirely is statistically indistinguishable from in the past. I mean, for younger nurses, that said, it's gone from essentially 0% in 2018 to like 2%, which statistically isn't significant, but the fact that anybody said in that age range they plan to leave the profession worries me a little bit. Yeah. The plan to quit and stay in nursing is very reflective of this, what you've heard in your histories.
Yeah.
But the historical piece, I'm just noodling over that. Like, what echoes similarly there? What's different?
I mean, it's something for me to sort of think about, thinking about interesting historical comparative cases as a way of sort of making sense of this. But I think it's interesting. One of the things that is fascinating to me about nurses is that the needs of healthcare organizations have always changed, right? And every time they change, nurses have to figure out how to respond, right? In ways that looks different from the kind of prototypical comparison of physicians, which, part of what it means, part of how physicians have been able to sort of protect their professional status is by keeping organizations out of their business for as long as they have. Right? So even though you can sort of say, well, they haven't been able to keep them out of business, they're not going to do that very much longer. It's amazing how rare and how likely they've been able to keep organizations out of their business. But since the admissions business has always been nursing's business. Right? They are always called to be, yes, they have a professional sense of their mission, but they have to work that out within what it is that employers expect them to do. They have had very little bargaining power in terms of telling the organization what they think nursing labor should do. The hospital generally tells them mostly what they actually sort of need. So I think for me, what is interesting about this historical moment is on one hand, yes, they are simply being asked, as they always have been, right, to sort of change what nursing practice sort of looks like. But I think that for me, there is something perhaps sort of, I don't know, different about this particular situation as it's happening. And part because I feel like there's even fewer degrees of freedom for nurses to sort of move within this particular set of constraints, right? It almost seems like an impossible, right? Because, I mean, I didn't talk about the sort of all the other things sort of in the data, but like, you know, I talked about the sort of normalization of traumatic experiences. One of my findings was that it just basically said, it's hard, but nursing work is always hard. Nursing work is always hard. This is another function, another kind of nursing work always being hard. So when you talk about the pandemic trauma as being the thing that was driving them out of nursing, what they were actually talking about is the hardness of doing the work within a particular set of strained relationships, the kind of sense of mission and, dare I say, joy that they got out of doing the work in either real or imagined, and being able to think about their connection and relationship to their patients is being severed. Right? The thing that made it worth doing every day feels like it's being severed in ways that has even fewer degrees of freedom than maybe some of the other historical cases. But I want to leave time for other questions, and so I'm going to stop there. Yes.
This was great. Thank you for bringing your work here. We really appreciate it. In particular, in some of the work that we were doing, one of the things we noticed is definitely the fracture between nurses and their relationship with patients, and the ways in which that relationship has really become militarized in terms of how to deal with whether it's families or patients themselves. And also a real difference in the fracturing between nurses and the C-suite, right? That is totally different from when we saw the only thing that was comparable was the AIDS wars back in the 80s, 90s, where you know the tensions and the mistrust of the C-suite is much more it's much more critical today, and it's much more fragile than it ever has been. And I haven't quite figured out why that is, but this is both someone who's embedded in this institution currently and someone who lived through those, and also some of the data that we've collected in a similar study that we've done, which I'd love to talk to you about later. But those two critical things have absolutely changed the whole face of nursing, and it's changed the commitment of nursing to this, so that the more technical aspects of nursing are becoming predominant, rather than the more kind of philosophical, empathetic, whatever word you want to use about what nursing actually was in the past. And I wonder if that's not what's generating folks to leave or to try to find a different way to kind of keep their foot, having one foot in the grave and one out.
Yeah.
But new nurses coming in, that's not the environment. That's not the environment, and they're not getting that experience either.
No, I mean, I already talked about that I had planned was there are all kinds of, things, right? Talking about that I didn't talk about, thinking about sort of younger cohorts of nurses, not having that dare I say, older, I mean, it was only a couple of years ago, the sort of older framework, right, for thinking about the value of nursing labor is no longer being modeled for them, because they're arriving on floors where the most senior person's only been there for 3 years, right? And so you actually, it's actually kind of amazing, like for people who might do sort of quantitative modeling of like the fusion of change, like there's just something like extraordinary about how quickly, right? That sense of what it means to be a nurse and what good nursing is, how quickly that has shifted in a kind of way for individuals, but also in a kind of generational sense.
More question, and then Jason has
When you were talking at the end of your talk about how kind of our definition of burnout is problematic, and going back to a comment you said about the broken architecture of social fabric, it kind of just kind of an aha moment, because I had this question about something I heard in a podcast a while ago about someone who studied PTSD, and they said, well, over 2 decades of war overseas, and they're saying, well, PTSD went up among combat veterans, which is not surprising, but it also went up among people who are not in combat, or even people who never even left the United States, which is kind of surprising. And it kind of, I was wondering if nurses who were not necessarily on the front lines per se, direct patient care, in those situations, are they also reporting more burnout? And I'm wondering if it's somehow sheds light on this other situation.
When you talk about, I think it's interesting how we define on the front lines, because it was actually fascinating when I sort of started doing this study. I've been watching the news and the New York Times and so you get all these stories, all these fairly sensational stories of nurses in the ICU. But only a small fraction of the nurses that I actually interviewed were working in the ICU. And only a fairly small fraction of nurses, because there were other kinds of patients, right? That also needed other kinds of settings that never even saw COVID patient, right? But I see again, there's like this idea of the trauma of the routine, right? This sort of idea that just going to work without working at the bedside of a patient who was might die over quickly over a 24-hour period, but that all of healthcare was a front line in ways that the nurses that I talked to talked about, even in settings that were not the acute care setting. I didn't actually have a lot of nurses in the long-term care setting because that's not really where most nurses work. But I did actually interview some CNAs who worked in long-term care, and that was a war zone that nobody talks about, right? People had stories of like the entire facility being filled with COVID-19 patients, patients with COVID-19, right? So even some of these places that we don't normally sort of visualize when we're thinking about it being on the front lines, all of healthcare was a front line during the pandemic. And I think for many of the nurses, they are continuing to experience healthcare as still being a continual front line, which is why many of them are trying to figure out how to stay if for no other reason that they've invested in a credential that allows them a middle class income, and they are not going to give that up easily, right? So they're trying to figure out ways to stay, even though it feels like a war zone almost every day that they go to work.
Thank you very much. Thank you.